A treatment of DKA and HHS comprise 4 important aspects. One is that a treatment is more or less similar in both conditions. You need to correct hypovolemia, since most patients are dehydrated. You need to correct the electrolyte disturbance, since most patients have lost a lot of electrolytes, namely potassium and sodium. And you need to correct the acidosis. A fluid replacement. In general, you need to be very generous in patients who are hypotension. Fluid replacement. You have to be very generous in patients who have hypotension. We recommend about 2 liters in the first 2 hours, 1 liter per hour. Thereafter, you need to infuse at a rate of 250 to 500 ml per hour, depending on the state of dehydration and depending on the level of sodium. So if the sodium level is less than 135, you continue the same normal saline. However, if the sodium is normal or elevated, it's preferable, especially in HHS, to switch to have normal saline. Once the blood sugar comes down to less than 250, which it frequently comes in a short time, then you need to switch the fluid to dextrose 5% or occasionally to dextrose 10%. This will allow you to maintain a continuous insulin infusion. Without changing to dextrose, you will not be able to maintain insulin infusion, which is important to prevention of lipolysis. And of course, you need to do high hemodynamic monitoring if abnormal renal or cardiac function. So in elderly who have decreased ejection fraction, you may need to do central venous monitoring. Insulin therapy is important and is paramount for the treatment of diabetic ketoacidosis. It reverses the abnormalities that I have explained in the pathophysiology of DKA, that is lipolysis. It promotes glucose uptake by the muscle and the fat cells, and it inhibits hepatic glucose protection. As such, I recommend that we give 10 units of regular insulin IV as a bolus, since this is very easily to administer very quickly and available in the emergency room, while awaiting insulin infusion, which again should be 100 units in 1 liter of saline, giving you a concentration of 1 unit per 10 ml. This concentration is easy to follow by the nursing staff. If the drop in glucose is very rapid, one could decrease the insulin infusion by 1 to 2 units. However, if there is no decrease in glucose, then one could increase the insulin infusion. There is no need, of course, to use insulin analogs, as regular insulin is given intravenously and that reaches target tissue very quickly. Remember all the time to check the IV line and to check the correct insulin concentration and infusion. Once DKA is resolved, one can change to subcutaneous insulin administration, and usually when acidosis is corrected and the patient is able to take food orally. If the patient is unable to take food for whatever reason, then we continue the insulin infusion until that patient is able to take oral food. And usually we recommend that you overlap by an hour between the intravenous and subcutaneously to allow the time that the insulin departs the intracellular fluid. Potassium treatment is extremely important in those patients, and hypokalemia is extremely dangerous for such patients. It leads to arrhythmias and therefore should be given paramount importance. In general, there is a sliding scale for potassium administration, so that when the potassium is very low, we administer more potassium. When the potassium is high, we usually withhold potassium. However, when the potassium is very low, we should really not start insulin until it is corrected. Such patients, of course, need cardiac monitoring. If the patient has potassium more than 5.5 or oliguria is present, then do not administer potassium. This graph shows what happens to diabetic acidosis over time. And as you can see, both beta-hydroxybutyrate, acetoacidase decreases, as well as acetone. Bicarbonate therapy is generally not recommended in most situations. It does not increase the rate of recovery from hyperglycemia or from hyperketonemia, and it doesn't affect the mortality of such patients. In fact, it may have potential disadvantages, such as it increases the risk of hypokalemia, it may accelerate ketogenesis, and you may develop post-treatment metabolic alkalosis. However, there are some indications for bicarbonate therapy. These include severe acidosis with a pH of less than 7, hyperkalemia, since administration of bicarbonate will decrease potassium level, hypotension and responsive to fluid replacement, severe left ventricular failure, respiratory depression, and late hyperchloremic acidosis. And if you have to give bicarbonate, you can put 100 millimole in 250 to 1,000 ml of half normal saline over 2 hours. If you give it with normal saline, that will be a little bit hypertonic to the patients. We also recommend that you administer potassium chloride, about 10 milliequivalent, added to prevent hypokalemia. Phosphate and magnesium also are deficient in those patients, and although they may be normal on admission, however, as treatment continues, the magnesium and phosphate become low with insulin administration. Studies, however, have shown no benefit of routine administration of those, and therefore we generally do not recommend phosphate repletion. In fact, phosphate level will become normal once the patient starts feeding. But they may be required in patients who are hypoxic for any reason, such as anemia, COPD, or CHF. And the dose we use about 20 to 30 millimole in 1 liter over 6 to 12 hours. There are possible adverse effects of hypophosphatemia, and the treatment is indicated in those conditions such as rhabdomyolysis, weakness, hemolytic anemia, respiratory depression, and CNS deterioration.